All right. Thank you, Dr. Smith, for joining. I think we can go ahead and start. So everybody, please switch our cameras on again. We're going to start with the second lecture for today. Dr. Smith, one of our attendings from nephrology at Mount Sinai Morningside Invest, will be presenting on nephrolithiasis.
Okay, so I'm not going to do the poll, but I have a bunch of questions throughout, about 11. And so I'm going to put up the questions, the answers. You can sort of think of the answers that you want, and then I'll sort of tell you what the answer is. And if you want to ask questions about the questions, feel free. So kidney stones. So the annual incidence of kidney stones has been increasing quite dramatically. This is the incidence per year, and it's this is total. This is a recent paper in the Journal of Urology. It's up to almost about 1% per year in the population. This is incidence again over time per year, and there's an increased incidence of kidney stones in men compared to women, but you can see women seem to be catching up or closing the gap. This is prevalence now of kidney stones. So the lifetime risk of having a kidney stone is somewhere around 10% for the whole population. Again, men a bit more than women, but there's a lot of risk factors that are associated with kidney stones, and being obese greatly increases your lifetime risk of having kidney stone versus normal weight. Diseases like diabetes increase your risk of kidney stones, and there's a lot of regional variation in who gets kidney stones too. Saudi Arabia, for example, I think is one of the areas with the highest prevalence of kidney stones lifetime. It's somewhere around 20%. And things that affect this would be things that you might expect, like high temperatures, more sunlight, and different sort of regional foods. So this is, again, the prevalence of kidney stones over time, over decades. And it's quite a dramatic increase since the 1980s. NHANES data of kidney stone prevalence, it's gone up from 4 to 5% to almost 10% now. And it's not really known exactly why this is, why there are more kidney stones now. Some ideas about this are increasing obesity, because we know obesity is associated with and causes kidney stones. More diabetes will cause more kidney stones. People have thought, well, maybe it's climate change, a hotter planet may be associated with this, and things like migration, more people moving to cities where there's sort of heat zones that more sort of might promote kidney stones. So again, the incidence is on the rise. And then the incidence of having a stone increases with age. It's actually pretty uncommon for a child or a young adult to have a kidney stone. So if you get someone who's young, this is sort of an indication to really think hard about maybe a more aggressive metabolic workup, or they may have a rare genetic cause for kidney stones. Again, men greater than women. Women seem to be catching up though. And there are racial differences, much more common to have kidney stones in Caucasians compared to Asians, and least common in Blacks. So if you have a first kidney stone, the chance of getting another one is actually quite high. Overall, it's about 5% per year after getting a second kidney stone for the first 5 years after you have your first kidney stone. But again, this is also highly variable and depends on a number of different factors and risks. So this is from the Mayo Clinic. You can get this online. You can get it at QXMD on your phone if you want. It's the risk if you've had a first kidney stone. It's a nomogram trying to figure out what's the risk of having a second one in 2 years, 5 years, 10 years. And it's a point system. And you sort of add up all these points and you look down here and you can sort of refine a little bit for the patient. What's the chance of getting another one? But overall, the risk is high. So some of the, I guess, more newer concept in stone disease, it used to be kidney stones used to be thought of as sort of episodic events. You get a kidney stone and then nothing for a bunch of years. And there's sort of these episodic things that you pass it and then it's over. But actually, nephrolithiasis probably represents in most patients some kind of systemic metabolic underlying disorder that they have. And sometimes we're able to sort of characterize and describe it, but sometimes not. But there is a systemic process that's sort of going on, even when they're not actively forming kidney stones. And so nephrolithiasis is definitely associated with a bunch of different diseases. Some of these diseases actually cause the kidney stones, and kidney stones actually can cause some of the diseases. So it kind of goes in both ways. Diabetes is definitely associated with kidney disease. Morbid obesity and metabolic syndrome probably themselves can actually in various ways cause kidney disease. Bariatric surgery, particularly the Roux-en-Y gastric bypass, definitely causes kidney stones. Chronic kidney disease, maybe the other way. So the stones are probably associated with and may actually cause chronic kidney disease. Hypertension, coronary artery disease. Coronary artery disease might be a shared risk factor. So if there's some disordered systemic problem with calcium handling that leads to calcification in kidney stones, it might also lead to vascular calcification. So that's a shared risk factor. Calcium stone formers typically oftentimes have a higher incidence of osteoporosis and fractures. And that makes sense because there's some dysregulated vitamin D and calcium handling that's going on. So so this is just an example of the shared risk factors, and some of them are shared and some of them are actually causal. The first question, a 45-year-old man is evaluated for abdominal pain for 1 day. The pain is intermittent and crampy, radiates to the scrotum on the right side. His medical history is notable for prostatitis 2 years ago and appendectomy. He's on no medication. Physical exam, he's ill, curled up on the exam table. He has a low-grade fever. Blood pressure is fairly okay. Heart rate 98. Exam is otherwise normal. White blood cell count is 11.5, creatinine 1.2. He's got blood in the urine. So which is the most appropriate imaging study to figure out what's going on with this guy? Sounds like he, from the description, he has a kidney stone. He might even have infection and sepsis from an obstructed stone. A couple seconds. I don't have a poll, but so the answer is non-contrast abdominal CT. And this is typically what will be done in the emergency room. What about the other answers here? Well, KUB may not be too bad. I mean, it's a quick initial screen. It's low radiation, but it's not very sensitive. It's only 60% to 70% sensitive. You're going to miss uric acid stones, which are, the radiolucent stones. Things like fecaliths and phleboliths can give you false positives. So it's really not the most adequate study. IVPs used to be done in the past, but you have to give IV contrast, and really that's no longer a common study that we get. So it's a non-contrast CAT scan that readily picks up most kidney stones, very high sensitivity, especially for calcium stones. This is a right stone here. They're very white and radiolucent, easy to see on the CAT scan. So a non-contrast CT, you can do a low dose radiation protocol if the patient has a BMI less than 30, standard dose if they have a BMI greater than 30. This is the gold standard. It really picks up all kinds of kidney stones. Even the radiolucent ones like uric acid can be seen with a non-contrast CT. And of course, it also gives you a differential diagnosis. If they don't have a kidney stone, you could maybe pick up other pathology. Very high sensitivity and specificity. The downside, of course, is that it's somewhat expensive to do a CAT scan, and the radiation exposure is not trivial. It's about 10 times the radiation exposure for a standard CT compared to a KUB. It also picks up very small stones, all the way down to about 1 to 2 millimeters. So you might find stones that are really asymptomatic, and you can get information about the stone burden. You might find an active stone that's causing the problem, but there may be stones elsewhere in the kidney or on the other side. So what about ultrasound? This is a renal ultrasound. This is the kidney, and you can see the stone here in the kidney with echo shadowing. It turns out that ultrasound isn't too bad. This was a study in the New England Journal from 2014, quite a large study done in the emergency room, where they looked at about 2,700 people coming in with what they thought was a kidney stone clinically, and they randomized them to either doing an ultrasound or a CAT scan. And it turned out that clinically, it didn't matter in terms of outcomes, is what their conclusion was. Outcomes meaning, worsening pain, hospitalization, return to the emergency department. So although the ultrasound in this study had less sensitivity for picking up a kidney stone, it was good enough to sort of manage them appropriately. And of course, the radiation dose was lowered. So ultrasound is an option. I think most emergency rooms still would go with the CAT scan because it gives you more information about what else may be going on if it doesn't turn out to be a kidney stone. So ultrasound might be an acceptable alternative, especially in the emergency room for an acute stone. It's actually very good for picking up obstructions. If you think if someone's kidney is obstructed, it's very good for hydronephrosis. It's necessary to do an ultrasound in pregnant women because you can't give them any radiation exposure. But of course, ultrasound will miss small kidney stones, and it misses stones that are farther down. It's best for picking up kidney stones that are up higher in the ureter. So distal stones will be less easily seen by ultrasound. Question 2. 50-year-old man. He's seen during a follow-up visit 4 days after he was evaluated in the emergency department for renal colic. He has a normal metabolic profile. And then they did a non-contrast CT, and they found a 6-millimeter stone in the mid-left ureter. He continues to have pain. It's now 4 days later but controlled with oxycodone. On physical examination, vital signs are normal. He's got mild costovertebral angle tenderness, and the remainder of the exam is unremarkable. So at this point, which of the following is the most appropriate next step in managing him? Would you do a 24-hour urine collection for calcium, oxalate, and uric acid? Would you repeat a non-contrast CAT scan? Would you give him temsulicin, Flomax, or does he need a urology referral to consider stone removal? Just a couple seconds on this one. So I think the best answer here is urology referral to consider stone removal. We'll talk a little bit about temsulicin, which is medical expulsive therapy, which some people might want to select for this. You could make some argument for that. I think that's not the answer, though. I don't think repeating a CAT scan is going to be terribly valuable at this point. And we don't do 24-hour urine collections for stone risk factor analysis in the setting of acute stones. You're really supposed to wait after this acute stone event is over and they're no longer having an acute stone to do the risk factor analysis with your 24-hour urine collections. So acute treatment for the kidney stone, of course, pain meds. It seems to be that Toradol and narcotics seem to be equivalent. Toradol has this theoretical advantage of decreasing ureteral tone and decreasing ureteral spasm. And we're all taught to give people IV fluid hydration. It's interesting. We do hydrate these people, but forced hydration by giving, trying to include, cause a diuresis doesn't seem to work, as you would think. A good randomized trial actually didn't seem to show that giving forced hydration was any better in terms of expelling the stone than maintenance, which is a bit surprising. Then this is the idea of medical expulsive therapy. It was in vogue for a while. It's sort of falling out of favor. This is to give a patient an alpha blocker like Flomax, temsulicin. And the idea is to sort of help the ureters kind of relax and get the stone expelled. It only seems to work maybe if stones are in the 5 to 10 millimeter range and they're in the distal ureter. If they're higher up, it's less likely to work. However, like I said, it's falling out of favor. There's small trials that show it works, other trials that show it doesn't. There's meta-analyses that show maybe it works. It's one of those therapies that we're not sure if it really does. One recent, very large randomized clinical trial really didn't support use of this. So it's still out there, but it's kind of falling out of favor, I think, this medical expulsive therapy. And of course, we'd like to strain the urine if possible to catch the stone for analysis, and that will help guide future therapy. It might even give us a clue about if someone has an underlying metabolic disorder that we might want to pay attention to. And the size of the stone matters. If a stone is less than 5 millimeters, we usually expect those to pass spontaneously. Not always. They could be barbed or jagged. So if it's small but has sharp edges and is stuck, it might not pass. In the 5 to 9 millimeter range, it may pass. We can try fluids, maybe an alpha blocker. And stones that are greater than 10 millimeters probably won't pass, and we really wouldn't give a trial of time. We would probably call urology right away if a stone is 10 or more millimeters in size. So urgent decompression, of course, is needed for someone who may have sepsis with possible obstructing stone. You need to have source control. If someone has bilateral stones causing acute kidney injury or obstruction of a solitary kidney by a kidney stone. So this can be done with a stent. The urologist goes in with cystoscopy and goes up and stents the stone, usually acutely, and then deals with extraction of the stone later on. Or sometimes we need interventional nephrology, interventional radiology, to come by and do a percutaneous nephrostomy to unobstruct the patient. So the urologists have a lot of new toys and techniques now to sort of get stones out, and probably flexible ureteroscopy is really becoming first line for treatment of kidney stones acutely. They have fancy new scopes that can really get to almost any part of the urinary system, and they're equipped with lasers on the end of these scopes that can break up stones. They can basket them. They can biopsy areas of the urogenital system. So this is probably the most, is becoming first line. Shockwave lithotripsy is still around, so it's somewhat center dependent. It also depends on the type of stone. So it's still, this works pretty well still for small kidney stones, so less than 10 millimeters that are sort of higher up or more proximal. Certain stones like cystine stones or certain kinds of calcium stones that are very hard don't really respond as well to lithotripsy. Then you have percutaneous nephrolithotomy. That's done where you actually make an incision in the back and you do an anterior approach to directly access one of the major calyces of the kidney. This is for big kidney stones, really large, greater than 2 centimeters, and kidney stones like staghorn calculi. And open surgical procedures in the OR are really rarely needed anymore. So types of kidney stones, majority of them are calcium, 80%. And of those stones, of those calcium stones, the majority of those are calcium oxalate. Those are the most common. And I would say probably of those, the most common are idiopathic calcium oxalate stones. But we also see calcium phosphate stones. And if you see a calcium phosphate stone, if you collected a stone for analysis and it turns out to be calcium phosphate, you might want to think of these diseases, underlying diseases, metabolic conditions that are associated with and may cause calcium oxalate, calcium phosphate stones. And they are type 1 renal tubular acidosis, hyperparathyroidism, and if certain medications like carbonic anhydrase inhibitors, Diamox, topiramate, medullary sponge kidney. So knowing the exact type of kidney stone sometimes gives you a tip off of what underlying disease might be causing the kidney stones if it's not idiopathic. Uric acid stones, 5 to 10%. These are the ones that are radiolucent on plain films, but you do see them on non-contrast CT. Struvite stones are the ones that form big staghorn calculi in the kidney. These are the magnesium ammonium phosphate stones. Those are the infection stones where you have urease producing bacteria that increase the urinary pH and cause the phosphate to be more insoluble. And then there are a bunch of other kinds of kidney stones that are genetic, that are rare but important not to miss. Cystine stones, xanthine stones, and dihydroxyadenine stones that are more common to see in young people. And of course, then there's multiple stone types. So sometimes we do stone analysis on these people, and there's the core is a calcium phosphate stone surrounded by calcium oxalate. So it doesn't have to be necessarily, or a uric acid core surrounded by calcium. It doesn't have to be exactly one kind. The pH matters in some of them, but for the majority of calcium oxalate stones, people who form calcium oxalate stones, those are pH independent. So pH doesn't affect the solubility very much of calcium oxalate. However, calcium phosphate stones are pH dependent and form in alkaline urine, where the phosphate gets deprotonated and becomes is able to complex with calcium. So that's why in type 1 RTA, for example, where you can never acidify your urine, you can't get the urine pH below 5.3, and you tend to have alkaline urine. That's one of the reasons why they're predisposed to calcium phosphate. And it also explains why if you're on a carbonic anhydrase inhibitor like topiramate or Diamox, and you're wasting bicarb because of the medication, you could see why you would be predisposed to calcium phosphate stones. Uric acid stones are the ones that are formed in acidic urine, and that's because uric acid is insoluble at a low urinary pH. And if the pH, we raise the pH with medicines, it's converted to urate, which is very, very soluble. And those can actually be dissolved by giving things like by giving the patient potassium citrate. And struvite stones form in very alkaline pH, and that's because those are the infection stones, and the urease-producing organisms produce ammonia and get the urine pH very high, and that causes insolubility of this magnesium ammonium phosphate crystals. So you can try to get an idea of what kind of kidney stone someone has by looking at the urinalysis. The urinalysis, of course, you'd look at the pH, you'd make note of that and see, does that make sense to correlate with one of the stones that you're thinking of? You might look for crystals in the urine. This is a picture of, this is calcium oxalate dihydrate crystals. Problem with this, though, is many of us have supersaturation for calcium oxalate in our urine, and we'll have these crystals, and we don't form kidney stones. So it's non-specific. It might be a tip-off if you see it, but it doesn't make the diagnosis of calcium stones. The X-ray may help, CAT scan to see how dense the stone is, gives you an idea that it's probably a calcium stone, which is the most common, versus more radiolucent stone, which would be a tip-off that you were dealing with a uric acid stone. But ultimately, really, to really know what kind of stones you're dealing with, you need to catch the stone and send it to a stone lab for actual formal stone analysis. The urinalysis, plain film, and CAT scan can only give you some basic clues. So kidney stones form because of many risk factors. So usually it's multiple risk factors that happen, and here they are. The most common one is calcium, having a high degree of calcium in the urine. And we call this hypercalciuria, but really this cutoff is quite arbitrary. We have a cutoff of greater than 300 milligrams of calcium per day in the urine. As considered abnormal, but the thinking has really changed a little bit, that it's really sort of a continuum of risk. So at any level of urinary calcium, you can form a kidney stone, and the lower your urinary calcium is, the less likely you are to form a kidney stone. The same is probably true of oxalate. We have a cutoff where it's sort of abnormal, but it's a continuum of risk, and the lower the urine oxalate is, the lower the risk of forming a calcium oxalate stone. So we have high uric acid levels. Citrate is an important one. Hypocitrate citrate is a stone inhibitor. So we can measure the urinary citrate. It's a very potent stone inhibitor. There are many stone inhibitors, but this is the one that we really measure and actually can manipulate clinically. So we're interested in looking at this as a stone risk factor in patients. I'll describe a little bit why high protein intake is a risk factor, high sodium intake is a risk factor. Of course, low fluid intake makes sense. That decreases urinary volume. And a prior history or a family history of kidney stone diseases increases your risk. So hypercalciuria, this question comes up, well, what is normal? It's classically defined as greater than 300 milligrams per day or greater than 4 milligrams per kilogram per day. But it turns out that even within the normal range, as the urinary calcium goes up, your risk for having a kidney stone actually goes up. So you can take a patient who has maybe a urinary calcium of 200, and you would say, the report would say, well, that's normal. They don't have hypercalciuria. If you lower their urinary calcium, if they're a calcium stone former, that may provide some benefit. So the idea of an absolute cutoff in a normal urinary calcium or not is falling out of favor. So it's really a continuum of risk. And this probably makes sense if you think about it, because it's not just the amount of calcium they make in the 24 hours, it's the concentration of calcium, and it's the supersaturation of the calcium with oxalate, and it sort of really matters. So this is a nice report that we get from a company called Litholink. So anyone who takes care of kidney stone patients, I think most of the people in the country are using this laboratory. This is a specialized stone laboratory. I think they're out of Chicago. And they provide you with a beautiful service. They send the patient a 24-hour urine container to collect the urine, and they pick it up by FedEx and bring it and then send back the doctor this really nice depiction of all the risk factors that you'd be interested in knowing. These are all the stone risk factors and measurements. It's one collection, one bottle. So that's good. In the past, we had to separate it for different substances. They had to have different measurements for you had to have different bottles. This is just one bottle, one collection. It can give you all these analytes. So this is how the report comes graphically. So this is the idea of sort of graded risk. So if we look here at urinary calcium, this patient has, a relatively low urinary calcium, 158 milligrams per day. And that's why it's sort of in the green area as lower risk. As the urinary calcium were to go up, it gets to be in this red area and that's sort of increased risk. So rather than having an exact cutoff, it kind of gives you sort of a visual idea for all of these different things where this patient is. And this gives you an idea of maybe what to treat, what to go after. And then they have a nice little area down here which gives you all these suggestions. So if you're ever taking care of a kidney stone patient, you want to do a 24-hour urine and look for risk factors, Litholink is the lab that everybody uses, and this is the kind of report that they give. So question 3. 36-year-old female evaluated for 3 stone events during the past year. Each episode was treated with analgesics in the acute care setting. She had uncomplicated passage of the stones, although none were recovered for analysis. Her father and brother also have kidney stones. Her only medication is a multivitamin. Normal blood pressure. Exam is unremarkable. Her calcium is normal, 8.9. PTH is normal. And these are her urine studies. So someone does a 24-hour urine for some of these risk factors. And we see here that everything is pretty normal except the calcium. So her calcium is 379 milligrams in 24 hours. So that's definitely abnormal. We would call this hypercalciuria. So it's definitely in the abnormal range. Her citrate is normal, oxalate is normal, and her urine volume is kind of low. So she's only making 1.5 liters per day. So in addition to recommending adequate fluid intake, because you would recommend that for everyone, which is the most appropriate next step in managing this patient. So she has hypercalciuria. Would we give her a calcium restricted diet? Maybe we should give her chlorothalidone, potassium chloride supplements, or sodium citrate. A couple seconds. And the answer is chlorothalidone, because chlorothalidone is a thiazide type diuretic, and thiazide type diuretics, as I'll discuss, decrease urinary calcium and are very effective in decreasing calcium stones in calcium stone formers. We can discuss a little bit about calcium restricted diet. That might seem like it makes sense if she has hypercalciuria. Well, why not restrict the calcium in her diet? Turns out that if you do that, you might lower the urinary calcium by restricting calcium in her diet. But what else happens is you increase the urinary oxalate. And I'll discuss why that happens as well. And the combination of the increased urinary oxalate that results from restricting your calcium in your diet is actually a worse effect, because calcium oxalate stones are very much more sensitive to small changes in the oxalate concentration as compared to lowering the urinary calcium. So calcium restricting diet is definitely wrong. Potassium chloride doesn't make a lot of sense. And sodium citrate, the citrate is good, but the sodium is bad. More sodium will increase urinary calcium. So this question was asked a long time ago. So if you have all these idiopathic calcium stone formers and they have hypercalciuria, why not treat with a low calcium diet? That sort of makes sense. So this is the famous Borghi study from 2002, and it really hasn't been repeated as far as I know. It's a 5-year randomized trial in Italy. They looked at 120 men with recurrent calcium oxalate stones, and they had idiopathic hypercalciuria. And they had 2 groups. They had just a low calcium diet group and a normal calcium diet group. And it turned out that group 2, which is the normal calcium, they had fewer stones. But they also had fewer stones than the low calcium group. So it turned out that low calcium, restricting calcium, was actually harmful. You had more stones in that group. And the explanation here is, again, because by restricting calcium, you actually had higher urinary oxalate in the urine, because calcium chelates oxalate. So it was an overall negative effect. So hypercalciuria is definitely probably one of the most important risk factors that we find in kidney stone formers when we do the 24-hour collection. Many of those are idiopathic. So we don't really know why they have hypercalciuria. We don't find any real specific pathologic reason, but there is a reason, we just don't identify it. These people tend to have an autosomal dominant inheritance. So there's something going on with calcium handling. They have normal serum calcium, so these people aren't hypercalcemic. but they may have mild to moderate increases in calcitriol, still within the normal range. So that's one theory of why we have idiopathic hypercalciuria. And there's different sort of classifications or types that really aren't important clinically because we don't really know what to do with them. Other reasons for hypercalciuria that are not idiopathic, though, primary hyperparathyroidism. They may or may not have a little bit of hypercalcemia or calcium in the normal range or slightly high. Sarcoid, they can actually have frank hypercalcemia and hypercalciuria. Type 1 RTAs generally have no hypercalcemia, but they've got bone buffers are releasing more calcium and phosphorus, and the calcium and phosphorus is excreted in the urine, so they can have hypercalciuria. High protein diet and high sodium diet, they don't have hypercalcemia, but both of these factors can increase the calcium in the urine, and I'll sort of explain in a subsequent slide why that is. So number 4, 52-year-old woman passes her first kidney stone that's presumed to be calcium. She has no family history of kidney stones. No other stones are seen on imaging. She gets a limited metabolic evaluation that's negative. She has a calcium in the normal range, but it's 10.2. So the best option at this time for her is to tell her to increase her fluids, but no other workup. Pursue a complete metabolic evaluation with the 24-hour urine collections for stone risk factors. Repeat the serum calcium with the PTH. Start her on a thiazide diuretic. Couple seconds. So the answer here is repeat the serum calcium with the PTH. So the key here is that they're giving you a calcium in a calcium stone former that's kind of high. It may be normal. Maybe the upper range of normal is 10.2 or 10.3. So she's got a high normal calcium. So it's suggesting that this woman might have primary hyperparathyroidism. Now, hyperparathyroidism is not the most common cause for kidney stones, but it's a condition that you don't want to miss because it's treatable, and it's a metabolic disease that you might want to act on and have specific therapy for. The other thing about this is, so you can have PTH that's sort of high normal or in the high normal range with high normalish calcium. And this can, one of the things you might want to send is a 25D level, because low 25D levels can sort of mask the primary hyperparathyroidism. So if you replete their D, then you'll sort of see more overt primary hyperparathyroidism. So restricting sodium in the diet of these patients can reduce hypercalciuria and decrease the recurrence of kidney stones. Nephrolithiasis associated with primary hyperparathyroidism, idiopathic kidney stones, both A and B, neither A and B. So restricting sodium in the diet. Well, that's one of our primary therapies for kidney stone formers. And it turns out, essentially, restricting sodium in the diet works for all stones, is kind of the answer here. It doesn't matter what the cause of kidney stones are, because by doing that, you're going to reduce the calcium in the urine. And I'll discuss why that is, but reducing sodium intake will reduce calciuria at whatever level you happen to start at, whatever your baseline is, and that's a beneficial effect on recurrent kidney stones. So that's, it even works for cysteine stones, because cysteine actually is reabsorbed. The reabsorption of cysteine is coupled to sodium. So if you decrease sodium, whatever transport you have ability to have to transport cysteine out of the urine, as sodium is pumped out of the urine because you're on a sodium restricted diet, you'll decrease cysteine in the urine too. So all stones respond to sodium restriction. So this is a little bit about renal calcium handling to sort of understand why some of these therapies work. So calcium is freely filtered in the glomerulus, and then across the nephron, it's reabsorbed. So your calcium gets filtered, and then 70% of that calcium gets passively reabsorbed in the first part, which is the proximal convoluted tubule. And it turns out that this is passively coupled to sodium. So as sodium is reabsorbed, calcium gets reabsorbed. So if less sodium is reabsorbed, less calcium is getting reabsorbed. So this is one of the reasons why you can treat hypercalcemia if you have a hypercalcemic patient with sodium chloride infusion. It's not necessarily because the patient's volume depleted, although they often are, but if you can give one of these patients lots of normal saline, they're going to dump that saline in the proximal tubule, and as they dump the sodium, they dump the calcium, because calcium follows sodium. They go together in this segment of the nephron. In the thick ascending limb, it's different. You get 20% of the calcium is reabsorbed there by sort of a voltage dependent, charge dependent mechanism. And that's set up by the Lasix sensitive sodium potassium 2-chloride channel. So if you give someone a loop diuretic, you block that channel and you prevent this sort of voltage gradient for calcium absorption. And that's why loop diuretics like furosemide will cause more calciuresis, more calcium in the urine. And then lastly, in the distal segment, in the distal convoluted tubule, this is where you have active resorption, where calcium is actually pumped back from the urine into the blood. And this is actually enhanced by thiazide diuretics. So thiazide type diuretics do the opposite in terms of calcium handling compared to loop diuretics. Thiazide diuretics will decrease calcium in the urine. So high sodium diet, well, that's a kidney stone risk factor. And this is because what we just said, because calcium reabsorption is passively coupled to sodium in the proximal tubule. So if you dump excess sodium because you're eating too much salt and you don't need the salt, kidney's trying to dump the sodium, it will dump calcium in the proximal convoluted tubule. They go together in the proximal segment. It turns out in real life, this works out because if you look at a large study like the Nurses' Health Study and you look at those people who have the highest quintile of sodium intake, they have a 1.3 times increased risk for symptomatic kidney stones. And it's probably because of the sodium that they're eating. Question 6. So which statement is false regarding the dietary influence on risk factors for kidney stones? So vegetable protein increases urinary calcium to the same extent as animal protein. Increased animal protein adversely affects substances that prevent and promote calcium oxalate stones. Restricting dietary calcium may increase urinary supersaturation of calcium oxalate. And the last one is restricting dietary fat may reduce oxalate excretion in patients with calcium stones. So I'll just put up the answers and I'll go through the reasons for this. But animal protein, as opposed to vegetable protein, increases urinary calcium. So it seems like vegetable protein doesn't have the same effect. And that's probably due to the acid load you get from animal protein as opposed to vegetable protein. Increased animal protein adversely affects substances that prevent and promote calcium oxalate stones. That's true because animal protein causes an acid load and that decreases urinary citrate. I'll talk about that. Restricting dietary calcium may increase urinary supersaturation of calcium oxalate. And that's true. That was proven in the Borky study because you get increased oxalate because calcium is needed to chelate oxalate. So if you restrict dietary calcium, you actually get increased oxalate, even though urinary calcium goes down. So the supersaturation, which is really important for stone formation of calcium oxalate, actually increases on a low calcium diet. So you don't want to restrict calcium. And then restricting dietary fat may reduce oxalate excretion in patients with calcium stones. That's true, and we'll discuss that why that's also a chelation issue and related to enteric hyperoxyl urea. So here's high protein diet. That's a risk factor for kidney stones. Why? Well, acid is generated for the metabolism of sulfur-containing amino acids, predominantly animal protein. When you have this acid load, this increases urinary calcium. And that's probably because the bones buffer this acid load. Calcium is released from bone and goes into the urine. Also, a fall in urine pH can promote uric acid stones because the uric acid stones, as we said, are very insoluble at a low urine pH. Acid load from the protein intake also decreases urinary citrate because as a compensation, proximally the kidney tries to reabsorb citrate, and citrate is a really great stone inhibitor. And if you don't have this stone inhibitor, you're going to form more stones. And this is probably less important. Animal protein has purines and they can lead to hyperuricosyria. So multiple mechanisms why animal protein can increase kidney stones. Probably the most important here, though, is the urinary calcium, and it tends to increase urinary calcium. So how do we treat recurrent calcium stones. It's also to make sense now if you understand all those issues. High fluid intake, well, that's true of all patients. We want to get the urine output to be probably greater than 2 liters a day. Decrease animal protein to 1 gram per kilogram per day. Decrease sodium intake because that will decrease calcium in the urine. Decreased sodium intake will cause decreased sodium in the urine and sort of less calcium, less calciuresis. And we do not want to limit calcium intake. We don't necessarily want to give calcium supplements. That might be an option, but if calcium supplements are used, they should be taken with meals and try to prefer something like calcium citrate. Drugs can be used to treat calcium stones. Typically, drugs are started if you still have active stone disease after 6 months of dietary therapy and dietary therapy fails. We can use thiazides and thiazide-like diuretics like hydrochlorothiazide. Probably the preferred is indapamine and chlorthalidone because those are more long-acting. And these decrease urinary calcium substantially, up to 50%. So whatever urinary calcium baseline you start from, even if you're not frankly hypercalciuric, you can reduce the urinary calcium by up to 50% with a thiazide diuretic, and that can be a big impact. Amiloride can be added on to the thiazides to go decrease the urinary calcium further if needed. So this is the distal convoluted tubule and how thiazides, briefly how thiazides work. Why do they decrease urinary calcium? Probably 2 mechanisms. They block this sodium chloride cotransporter here in the distal tubule. They cause mild volume depletion. And in the setting of mild volume depletion in the proximal tubule, you're going to reabsorb more sodium because you have volume depletion. And as the proximal tubule absorbs more sodium, calcium goes with it in the proximal tubule. It's coupled. So you get more calcium reabsorption from the urine. And the second mechanism here is in this distal segment. If this channel is blocked, you increase the flux of calcium into the cell and you activate this cotransporter, this sodium calcium cotransporter, and you actively pump with thiazides on board. You actually will end up pumping calcium out of the urine and decreasing the urinary calcium. So thiazides decrease urinary calcium, but you need a low urine sodium diet. So if someone's on a thiazide and they have a high sodium intake, you can sort of negate the effect of the thiazide. So it has to be coupled. You have to avoid hypokalemia, which thiazides can cause. Hypokalemia can trigger an intracellular acidosis and result in decreased urinary citrate excretion. And you need citrate as a stone inhibitor. So people who take thiazide diuretics for stone prevention, you need to have these 2 things in play. They have to low sodium diet and avoid hypokalemia. You can also give patients very commonly potassium bicarbonate or more commonly potassium citrate. The common one you'll see is Urocit-K. There's other preparations. These do 2 things. These by themselves also decrease urinary calcium, but they can also increase urinary citrate directly. And like I said, that's the stone inhibitor, most important stone inhibitor. There's one negative effect, potentially negative effect of giving potassium citrate. These can trigger calcium. We think they might be able to trigger calcium phosphate stones because those are the stones that are pH dependent and they can form if the urinary pH goes over 6.5. So it's a bit unknown if you have a calcium phosphate stone former, whether potassium citrate, the beneficial effects of the citrate will be outweighed by the potential negative effects of increasing the urinary pH. There's never really been a study to sort of sort that one out. There are other ways of giving citrate. You can give it as 10 lemons a day, or this over-the-counter preparation called Moonstone. It has a high citrate concentration. Question 7, 45-year-old white man passed a kidney stone at home, right flank pain, now resolved. He's concerned about subsequent stone formation. He has a history of a small bowel resection due to Crohn's disease several years ago. After his surgery, he had a similar episode of flank pain on the left. Before that, he had no history of kidney stones, and his family history is negative for kidney stones. Since the surgery, he has had no other complaints except for frequent bowel movements. Current medications include calcium carbonate and 1 aspirin. So which of the following in this patient is most likely to contribute to stone formation? Increased urinary oxalate, decreased urinary oxalate, increased calcium intake, increased urine citrate level, increased urine pH. So the answer here is increased urinary oxalate. This is enteric hyperoxyl urea with someone who seems to have fat malabsorption. I'll discuss. This is a favorite question, I think, on tests, on board questions. 54-year-old female is seen for recurrent kidney stones, underwent successful gastric bypass surgery a year ago. Her BMI decreased from 38 to 33. She's had 2 episodes of nephrolithiasis since the time of surgery. No stones are available for analysis. She's got type 2 diabetes and hypertension. Medications are metoprolol glyburide. Physical exam is fairly unremarkable. You have some urine studies. They did 24-hour urine studies, and they're not giving you the numbers here, but her 24-hour urine calcium is normal, citrate normal, oxalate high, uric acid normal. Her volume is quite low, 1,300 cc's per 24 hours. And you see many envelope-shaped crystals. These are the calcium oxalate dihydrate crystals on her urinalysis. So in addition to telling her to increase her fluid intake, which of the following is the most appropriate step in the management of her kidney stones? Low fat, low oxalate diet with calcium supplements. Would you give her chlorothalidone? Would you give her potassium citrate or tamsulicin? So the answer is, this is another case, a second case of enteric hyperoxyl urea. These are very difficult to treat. So once these patients have, there's no real medicine that works very well for these calcium oxalate stone formers. And oxalate really, if they have hyperoxyl urea, it's really hard to get that down. So we want to give them a low-fat diet, a low oxalate diet, maybe calcium supplements to help chelate the oxalate so they don't absorb it. Other options here, chlorothalidone. Well, that might decrease urinary calcium, but that's not her primary problem here, and that may not have much of an effect. Potassium citrate might be an idea. Certainly, if she had metabolic acidosis from the chronic diarrhea, that could be an answer, but it's not the primary problem. And tamsulicin Flomax, that's for the acute stone. So enteric hyperoxyl urea is a condition where there's any cause of fat malabsorption. Oftentimes it's surgical from small bowel disease and resections in Crohn's disease, gastric bypass, but it can even be caused by the medicine orlistat because that causes fat malabsorption. So anything that causes fat malabsorption and bile salts in the terminal ileum can lead to binding of calcium. These free fatty acids actually bind and chelate calcium. And what this causes is decreased calcium availability in the large bowel, in the colon. And in the colon, oxalate is normally complexed with calcium and excreted in the stool. But if there's not a lot of calcium available to complex with the oxalate, you get increased colonic absorption of the oxalate. And that's the enteric hyperoxyl urea. So the oxalate gets absorbed. So you need a functioning colon for this. So people who have colectomies don't get enteric hyperoxyl urea. It's the small bowel pathology that does it and the fat malabsorption that does it. So this oxalate that gets absorbed ends up getting excreted in the urine. So hyperoxyl urea is a kidney stone risk factor. So there are dietary causes of this. This tends to be not, unless someone's really dietary issues cause really mild elevations in the urine oxalate, unless someone's eating massive amounts of certain foods that sort of have high oxalate content. So we do dietary histories. Some people are spinach lovers every night and eating tons of it. So if you find that, you might want to decrease that. But this is not a major cause of high urine oxalate levels. Enteric hyperoxyl urea, you would have this history. You'd have this history of fat malabsorption or surgery, and that can cause a lot more severe elevations in the urinary oxalate. Low dietary calcium could be a reason because you need the calcium to bind the oxalate in the colon to prevent that oxalate from being absorbed. High doses of vitamin C, megadoses of vitamin C could be a cause. Vitamin C can actually be converted to oxalate in an alkaline urine. So again, the medical history and history of dietary things and supplements. It's been reported things like turmeric really high doses. People think that that's healthy for them and they take mega doses of it. It has a lot of oxalate, and cranberry pills these have all been reported to cause, oxalosis and hyperoxyl urea. And then there's a bunch of congenital disorders that can cause end-stage kidney disease. So question 9. 31-year-old woman passed a kidney stone 2 days ago. She's had multiple renal stones over the past 10 years. For the past 2 years, she's had Raynaud's, as well as dry eyes and dry mouth. So this is her BMP. Looks like her bicarb is kind of low, 20. I guess the anion gap here is normal. Hyperchloremia. She's got hypokalemia. Urinary pH is 6.5. And she's got some red cells in the urine and blood. You do an abdominal plain film. She's got multiple calcifications overlying both renal shadows. So this is nephrocalcinosis. So the most likely cause for renal stones in this patient is idiopathic hypercalciuria, cystinuria, renal tubular acidosis, struvite stones, or medullary sponge kidney. Answer here is renal tubular acidosis. So they're trying to give you hints that this patient has Sjogren's disease, dry eyes, dry mouth, Raynaud's. And Sjogren's disease is one of the more common causes of type 1 distal RTA. And distal RTA is associated with kidney stones. The most likely type of stone in this patient with distal RTA and kidney stones is calcium phosphate, calcium oxalate, uric acid, triple phosphate, that's the infection stone, or cysteine. And the answer is calcium phosphate stones. This is something you just have to memorize. I don't think you can figure this out, but distal RTA is one of the, if you have a calcium phosphate stone, you should think about distal RTA. If someone has distal RTA, you should think maybe they have calcium phosphate stones. So in distal RTA, the urine pH is elevated. You're not able to acidify your urine ever. And calcium and phosphate are both released from bone buffers because of the acidosis, and they end up in the urine. So you get hypercalciuria and hyperphosphaturia to cause the calcium phosphate stones. And it turns out the calcium phosphate is less soluble at a higher urinary pH. Also, because you have an acidosis, you get hypocitraturia, low citrate in the urine, because of proximal reabsorption of citrate in the setting of the acidemia, and that causes the calcium phosphate stones. In addition, you get nephrocalcinosis because you get calcium phosphate stones and crystals that plug the intermedullary collecting ducts. So that's the nephrocalcinosis that you'll see on the plain films. This is sort of a classic description of someone with distal RTA in calcium phosphate stones. Hypocitraturia, so low citrate is a risk factor for kidney stones. Citrate is a stone inhibitor. Complexes with calcium inhibits the stone. So there are multiple factors that might decrease citrate in the urine. One is any chronic metabolic acidosis, like type 1 RTA or diarrhea. Medicines can do it. Again, these are the carbonic anhydrase inhibitors that patients might be on. High protein diet will reduce citrate in the urine because of the acid generation, the acid load. Hypokalemia, chronic hypokalemia causes intracellular acidosis and reduces citrate acid in the urine. And of course, there's the idiopathic reasons that we don't seem to find any reason. Of course, there's other stone inhibitors, nephrocalcin, Tam-Horsfield protein, magnesium pyrophosphate. We don't tend to check or measure these because we don't really are not very good at manipulating. So it's all about citrate. This is just the effect of any metabolic acidosis causes citrate absorption. Citrate gets converted to bicarb, so it makes sense why the body and the kidney, in the setting of an acidosis, would want to reabsorb all your citrate in the proximal tubule. So that's good for the body and good for the acidosis, but bad for the kidney stones. 30-year-old man has Crohn's disease, right flank pain, vesicular rash over the right flank, a 0.5 centimeter radiolucent stone in the right pelvis. What's the most appropriate therapy? Shockwave lithotripsy, ureteroscopy with stenting, fluids, and potassium citrate to dissolve the stone, surgical removal. So this is one of the few kinds of kidney stones that can be dissolved because it's a uric acid stone. The key is that it's radiolucent. And you'd want to give this patient potassium citrate. If you can raise the urine pH over 6, the uric acid becomes very soluble and the stone can actually dissolve. Why does this person have uric acid stones? We don't know, but potentially he's got Crohn's disease, chronic diarrhea perhaps, and a chronic metabolic acidosis. If you have a chronic metabolic acidosis, persistently acid urine, that's going to be a risk factor for uric acid stones. So these are 10 to 15% of all stones. The risk factors primarily is low urine pH. That's the most important risk factor, chronically low pH. Low urine volumes, that's true for all stones. Hyperuricosyria is not as important as you would think. It's really mostly about the pH and the solubility. Chronic diarrhea can do it. Metabolic acidosis causes increased concentration of the urine. Therapy, increasing the volume. You want to alkalinize the urine with potassium citrate. Sometimes if this doesn't work perfectly, you can come in with allopurinol, but the primary therapy is potassium citrate. Hyperuricosyria is also a kidney stone risk factor. Multiple things here on this list can cause it. Low urine volume, of course, is important. Sort of obvious. We want to increase the urine volume to 2 liters a day. Drink fluid at night, throughout the day. Try to keep the urine pale, light yellow. That's some advice that's given. Medullary sponge kidney, have to mention, it's a developmental abnormality where you have these tiny dilation, tiny cysts, tiny medullary cysts, microcysts. It may be as common as 0.5 to 1% in the population. Seems to be asymptomatic in most patients. There's some kind of autosomal inheritance with familial clustering. But in kidney stone formers, this may represent up to 15 to 20% of what we're calling idiopathic calcium stone formers. And these little tiny microcysts in the medulla, you're thought to have urinary stasis, and that's where the stones may start forming. You can also see nephrocalcinosis in these patients, and they have other stone risk factors. We don't really diagnose this very much. We know it's out there, but you need an IVP, which we don't do anymore to diagnose. It was diagnosed more frequently in the past. You could do a CT urogram. That's typically not done either. This is medullary sponge kidney, and this is not an IVP, but these little, this is an IVP, sorry. This is an IVP where you give contrast, and these little arrows are the little cystic out pouches where the contrast is sort of collecting. So there's a whole bunch of other kidney stone risk factors. I mentioned enteric hyperoxyl urea, hypertension, recurrent UTIs. Certain juices actually increase, certain drinks seem to increase the risk. Fructose, cola, and sucrose. But some kind of liquids or drinks actually decrease. Lemon juice and orange juice seem to decrease the risk. That makes sense because they have citrate. Citrate is a stone inhibitor. For reasons that I don't think we understand, beer and coffee are associated, they're liquids that are associated with decreased risk. Chronic diarrhea, family history is important. A couple words about struvite stones. They're generally asymptomatic unless they fragment and break off and enter the ureter. This can cause chronic kidney disease and end-stage kidney disease from obstruction. These stones can grow and fill up the entire collecting system and grow sometimes quite rapidly. And this is formed predominantly by upper urinary tract infection by organisms, urease producing organisms such as Proteus and Klebsiella. And these produce a very alkaline urine. In the very alkaline urine, this decreases the solubility of phosphate, and you can form this triple phosphate sodium ammonium phosphate stones. So women tend to form pure struvite stones, the more common when they get urinary infections. Men often have calcium stones that then get super infected, and that the calcium stone can now turn into a struvite or staghorn calcium. This is a urinalysis with struvite crystals, what they may look like. They're described as sort of this coffin lid kind of. This is magnesium ammonium phosphate crystals. And this is staghorn calculi on a plain film. This is not an IVP. This is the staghorn calculi are just sort of lighting up here without any contrast, bilateral. Struvite stones are very difficult to treat. We try to give them antibiotics. You can never really sterilize these stones because they're infected. The antibiotics don't penetrate. There are some other medicines that are tried that don't work very well, like this acetohexamic acid. Oftentimes you need urology to really go in there, do multiple combined procedures. Sometimes oftentimes they're too big to go in through the bladder. You have to go in anterograde with nephrolithotomy. So what do you do for the workup for a first stone? So typically what's recommended is a limited evaluation for a first kidney stone former. You want to do a dietary history, make sure they're not megadosing on vitamin C or D or taking lots of protein or high sodium. A BMP with a serum calcium, and pay attention to the calcium, because if the calcium in a woman is sort of high normal, you might want to send a PTH and make sure you're ruling out primary hyperparathyroidism. A simple urinalysis with pH and a culture might be helpful, easy to do. Recommend everyone gets high fluid, and you might want to monitor them with simple things like KUB or an ultrasound. So an extended metabolic evaluation, who do you do that in? These are people who have recurrent kidney stones, they're having more than one, multiple stones on presentation. So they show up with their first kidney stone, but then you do a CAT scan and they've got stones bilaterally or on both sides. Very large kidney stones. They need a urologic procedure. They're obstructed. You probably want to think about doing a extended evaluation, strong family history, or if you get one of these people who is either pediatrics or a young adult, where kidney stones are less common, you probably want to do more extensive evaluation. And that basically includes all the blood workup, but probably 2 good 24-hour urine stone risk profiles with at a lab like Litholink, and you try to do these after the acute stone event when they're on their normal diet. You send for these different things. Hopefully you can actually catch the kidney stones and send it to a stone lab. This is my last slide. So if you remember one thing from this lecture, it's these points. So this is what you can, this is advice that you can give for all kidney stone formers. So even if you don't do any metabolic evaluation, you don't know what kind of kidney stone they have, these points, these therapies, these treatments kind of work for everybody. So of course, weight loss, because weight loss is associated with metabolic syndrome and defect in ammoniogenesis and increased risk for kidney stones. Increased fluid intake for everyone. That can be done with water. It can be done safely with coffee. And we think coffee seems to have a benefit in multiple studies for a reason we don't know. Juice, lemonade and orange juice, which has citrate, possibly even beer, but we don't really recommend beer. But if someone's drinking beer, as far as the kidney stones goes, that actually seems to be helpful for kidney stones. Medications, doesn't matter what kind of kidney stone you have, potassium citrate seems to work. Citrate is a potent stone inhibitor. It decreases urinary calcium and inhibits stones. It might be detrimental if someone has calcium phosphate stones, but it seems to work in all other cases. Chlorthalidone will lower the urinary calcium. Doesn't matter where they start, whether they're hypercalciuric or not, whatever baseline urinary calcium they have, it will lower it. And then the Borghi diet from that study from 2002, this seems to work for all kidney stones. So decrease their sodium intake, decrease animal protein, and increase perhaps dairy like calcium that can chelate, oxalate, and decrease oxyl urea. And I think that's it.
Thank you, Dr. Smith. If anybody has questions, you can ask them now. Patrick is asking, can you please share your earlier summary slide with the pH levels?
This slide? What?
Is this the one, Patrick?
Or the type of kidney stones with the pH?
I think the type, yeah. Thank you.
That's the one. Thank you very much.
All right. If no other questions, we can take a short break. Thank you so much for joining us, Dr. Smith.